Hello and welcome to my YouTube channel. I'm going to talk about hyperlipidemia treatment. I will be making a whole series of videos, so please subscribe to my YouTube channel and get some notification of my educational videos. Thank you. Okay, we're going to begin with question 1. Which is the overall goal of treating hyperlipidemia? The answer is B, to reduce arthrogenesis. Arthrogenesis involves more than just deposition of lipids. In fact, arthrogenesis is now considered primarily a chronic inflammatory process. When low-density lipoproteins penetrate the arterial wall, they cause mild injury. The injury, in turn, triggers an inflammatory response that includes infiltration of macrophages, T lymphocytes, and other potentially toxic chemicals such as your C-reactive protein. In the late stage of the disease process, inflammation can weaken atherosclerotic plaque, leading to plaque rupture and subsequent thrombosis. So the goal is to reduce arthrogenesis. It is important to know that in 2013, the American College of Cardiology and the American Heart Association put out a cholesterol guideline, and their focus was on the role of high cholesterol in atherosclerotic cardiovascular disease, ASCVD, and stresses the importance of treatment. However, the new guideline focuses specifically on identifying patients who are more likely to benefit from cholesterol-lowering therapy instead of targeting specific cholesterol goals. Cholesterol has a large impact on atherosclerosis. That's your thickening of the coronary arteries, also known as ASCVD, your atherosclerotic cardiovascular disease. ASCVD includes the vessels of the heart as well as the brain. Damage to these vessels can result in myocardial infarction or stroke. Moderate cardiac ASCVD usually manifests first as anginal pain. Severe cardiac ASCVD sets the stage for acute coronary syndrome, NMI. In the United States, cardiac ASCVD is the leading killer of men and women, causing about 801,000 deaths in 2013. So basically, your desired outcome would be for your patient is to lower total and LDL cholesterol to reduce risk of first or recurrent events such as MI, angina, heart failure, ischemic stroke, or other forms of peripheral artery disease such as carotid stenosis or abdominal aortic aneurysm. Next question. The first line therapy for hyperlipidemia is, the answer is C, therapeutic lifestyle changes. To reduce LDL levels, the 2013 American Cardiology, College of Cardiology and American Heart Association guideline recommends two forms of intervention. The first one is therapeutic lifestyle changes, and the second is drug therapy. For some people, cholesterol can be reduced adequately with TLC, that's the therapeutic lifestyle changes, alone. Others require TLC plus cholesterol-lowering drugs. So please note that drugs should be used only as an adjunct to TLC and not as a substitute. Therapeutic lifestyle changes are non-drug measures used to lower LDL cholesterol. TLC focuses on four main issues: diet, exercise, weight control, and smoking cessation. These measures are first-line treatment for LDL reduction and should be implemented before drug therapy. However, TLC can be a challenge because some people do not eat healthier diets or exercise. Physical conditions such as arthritis can limit attempts at exercise, and economic and time limitations can be a barrier to healthier eating. Drugs are not the first-line therapy for lowering LDL cholesterol. Rather, drugs should be employed only if TLCs fail to reduce LDL cholesterol to an acceptable level, and then only if the combination of elevated LDL cholesterol and the patient's ASCVD risk category justify drug use. When drugs are used, it is essential that lifestyle modification continues because the beneficial effects of diet and drugs are additive. Drugs alone may be unable to achieve the LDL goal. It is important to note that the principal benefit of drug therapy is primary prevention. Drugs are much better at preventing or slowing ASCVD than at promoting regression of established coronary atherosclerosis. Furthermore, because LDL cholesterol levels will return to pre-treatment values if drugs are withdrawn, treatment must continue lifelong. Patients should be made aware of this requirement. The most effective agents are the hydroxymethylglutarol CoA reductase inhibitor. That is your HMG CoA reductase inhibitor, such as your atorvastatin, that's your Lipitor. They are also simply referred to as statins. Okay. According to the 2013 American College of Cardiology and American Heart Association blood cholesterol guideline, all of the following patients would benefit from statin therapy except, and then you have your choices here. Your answer should be E, a 35-year-old smoker with hypertension. Okay, the 35-year-old patient might be a candidate for statins, but it is not an automatic candidate based on the information given. All other options describe patients who would benefit from statin therapy according to the 2013 ACC/AHA guideline. And the guideline also relies on risk calculator for primary prevention, and you can find them online under tools.cardiossource.org/ASCVD-risk-estimator/. Patient teaching is very important. Expectations should be clear about what the drugs can and cannot do. Drugs are supplements to dietary and other lifestyle modifications, not substitutes for them. Lipid disorders are chronic conditions. Lifestyle modifications and drug regimens need to be incorporated into patients' daily lives. Discontinuation of treatment will result in return of lipids to pre-treatment levels. Adherence is also very important. Non-adherence to the treatment regimen may increase patients' risk for cardiovascular morbidity and reduce their life expectancy. Healthcare providers should be aware of potential problems with adherence. Discuss the importance of adherence at each follow-up visit and assist patients in removing barriers to adherence, such as lack of social support and fear of side effects. Utilization of other health team members, especially the dietitian, should be maximized. Patient education booklets available from the American Heart Association and the National Cholesterol Education Program may supplement dietary instructions. The lab results of a 55-year-old African American are total cholesterol of 175 milligram per deciliter. LDL is 110 milligram per deciliter. HDL is 35 milligram per deciliter, and triglycerides are 150 milligram per deciliter. He is a non-smoker and a non-diabetic. He does not take medications at home. His systolic blood pressure is 132 millimeters of mercury. You enter all these data into the ASCVD risk calculator and generate a 10-year ASCVD risk of 7.5%. Being consistent with the 2013 ACC/AHA guideline, you recommend, and you look at the choices, your answer is D, moderate to high intensity statin therapy. The 2013 American College of Cardiology/American Heart Association guideline has changed the way we determine risk, expanding the use of statins. Patients whose 10-year ASCVD risk is 7.5% or greater should be on moderate to high intensity statin therapy. The guidelines highlighting a 7.5% risk level are not meant to be absolute standards for starting medications, but only a trigger point for consideration of personal risks. These risks fall into modifiable and non-modifiable categories. The modifiable risk factors such as diet, smoking behavior, and exercise are targets of therapy through lifestyle modifications. Non-modifiable risk factors include race, age, gender, and family history. Ethnicity is also now a recognized risk factor for coronary heart disease. For the first time, there are recommended treatment algorithms for lipid management based on race and gender differences in risk factors. A 60-year-old woman with an LDL of 132 and a family history of coronary artery disease. She has already tried diet changes. She has increased fiber and plant sterols to lower her LDL levels, and after 6 months, her LDL level is slightly higher. The next step in her treatment would be, your answer should be A, a statin. Statin therapy is recommended for lipid management in patients who have clinical cardiovascular disease, diabetes, or are over 40 years of age. Statins may also be added to therapy if patient has multiple cardiovascular risk factors. The statins have several actions that can benefit patients with or at risk of atherosclerosis. The most obvious and important are reduction of LDL cholesterol. Statins have profound effect on LDL cholesterol. Low doses decrease LDL cholesterol by about 25%, and larger doses decrease levels by as much as 63%. Reduction are significant within 2 weeks and maximal within 4 to 6 weeks. Because cholesterol synthesis normally increases during the night, statins are most effective when given in the evening. It is typically recommended that the statins with shorter half-lives be administered in the evening or at bedtime, like your simvastatin. The other name is Zocor. Drugs with long half-lives, like your atorvastatin, Lipitor, and rosuvastatin, which is your Crestor, may be administered any time of day. While it is unknown whether the timing of statin administration is important for clinical outcomes, typically statins should be administered at the time recommended by the manufacturer. Rosuvastatin is considered the most potent drug in the class, with an adverse reactions profile similar to that of atorvastatin, but considered higher risk. The usual starting dose is 5 mg to 20 mg per day, with a maximum of 40 mg per day. Atorvastatin is the next most potent and has the best adverse reaction profile. The usual dose is 10 mg per day initially, increased at 2 to 4 weeks interval up to 80 mg per day. Taking lovastatin with food enhances its blood levels. Grapefruit ingestion should be avoided with simvastatin, lovastatin, and atorvastatin. Clinical trials have shown that statins slow the progression of ASCVD and decrease the risk of stroke, hospitalization, cardiac events, peripheral vascular disease, and death. Benefits are seen in men and women and in apparently healthy people, as well as in those with a history of cardiovascular events. Hence, the statins are useful for both primary and secondary prevention. Furthermore, these drugs can help people with even normal LDL levels, in addition to those whose LDL levels is high. Statins may also have some added protective effects in people with diabetes. If statin therapy is stopped, serum cholesterol will return to pre-treatment levels within weeks to months. Therefore, treatment should continue lifelong unless serious side effects or particular contraindication such as pregnancy or muscle damage arise. A 65-year-old woman who has been on lipid-lowering diet and using plant sterol margarine daily for the past 3 months. Her LDL is 135 milligram per deciliter. An appropriate treatment for her would be D, determined by her risk factors. Plant sterols and stanols are substances that occur naturally in small amounts in many grains, vegetables, fruits, legumes, nuts, and seeds. Since they have powerful cholesterol-lowering properties, manufacturers have started adding them to foods. You can now get stanols or sterols in margarine spreads, orange juice, cereals, and even granola bars. There are some experts that believe the 2013 guidelines recommend treatment for too many people. Approximately 45 million more Americans are now being considered as at risk for cardiovascular disease and within the guideline recommended parameters for use of statins. Some experts say that this is without merit. Others believe that there is a significant overestimation of risk up to 154%. The guideline authors counter these arguments with an emphasis upon an individualized personal risk evaluation with discussions of the risks between patient and provider. The new goal is a progressive reduction of LDL levels. Therapeutic lifestyle change is initiated and continued for 3 months. After 6 weeks, the LDL panel is redrawn and dietary enhancers of LDL lowering, such as your plant stanols or sterols and your viscous fiber, are increased if needed. After 3 months, another LDL panel is drawn. If LDL cholesterol has lowered, the therapeutic lifestyle change therapy is continued. For LDL cholesterol of 160 to 189 milligram per deciliter, drug therapy is optional. The presence of influential factors such as smoking, poorly controlled hypertension, or very low HDL suggests the risks are not low and drug therapy should be initiated. If the LDL cholesterol remains above 190 milligram per deciliter despite therapeutic life change therapy, drug therapy is the more likely treatment option. Some patients may present with very high LDL cholesterol levels, that is like greater than 220 milligram per deciliter. These individuals usually have a genetic form of hyperlipidemia that cannot be treated adequately with therapeutic lifestyle changes alone. These individuals will require drug therapy. A 56-year-old male with multiple risk factors who has been on a high-dose statin for 3 months to treat his high LDL level, but his LDL level cholesterol is still 145 milligram per deciliter, and his triglycerides are elevated about 195 milligram per deciliter. As his primary care, what would you do? So you would look at the answers and choose answer C, continue the statin, and add ezetimibe. Ezetimibe is the other name is Zetia. In clinical trials, ezetimibe, which is Zetia alone, reduced LDL cholesterol by about 19%, increased HDL cholesterol by 1 to 4%, and decreased triglyceride by 5 to 10%. It is not considered a first-line therapy. In combination with a statin, it should increase LDL reduction. Ezetimibe is available in a combination product with simvastatin, which is a good combination drug that will decrease the amount of pills the patients will have to swallow. And the combination is a fixed combo dose, and the name is Vytorin. Okay, it's a combination of simvastatin and ezetimibe. The mechanism of action of Zetia, or the other name is ezetimibe, acts on cells of the brush border of the small intestine to inhibit dietary cholesterol absorption. The drug also inhibits reabsorption of cholesterol secreted in the bile. Treatment reduces plasma levels of total cholesterol, LDL cholesterol, triglycerides, and apolipoprotein B. In addition, Zetia can produce a small increase in HDL cholesterol. Zetia is indicated as an adjunct to diet modification for reducing total cholesterol, LDL cholesterol, and apolipoprotein B in patients with primary hypercholesterolemia. The drug is approved for monotherapy and for combined use with a statin. When Zetia is combined with a statin, the reduction in LDL cholesterol was about 25% greater than the statin alone. Despite these desirable effects on blood lipids, there is no evidence that Zetia reduces atherosclerosis or improves clinical outcomes. Adverse effects are myopathy, rhabdomyolysis, hepatitis, pancreatitis, and thrombocytopenia. In contrast to bile acid sequestrant drugs, ezetimibe does not cause constipation and other adverse GI effects. In patients taking a statin, adding Zetia slightly increases the risk of liver damage, as indicated by elevated transaminase levels. If the drugs are combined, transaminase levels should be monitored before starting therapy, as well as whenever clinically indicated thereafter. Combining Zetia with a statin may also increase the risk of myopathy. Contraindications for ezetimibe is hypersensitivity, concomitant use with a statin if active hepatic disease exists, unexplained persistent elevated transaminase, and pregnancy. Precautions are of history of liver disease or renal impairment. Drug interactions for ezetimibe is that ezetimibe levels may be increased by cyclosporin and may be decreased by bile acid sequestrants. A 59-year-old male presents to your office for a routine follow-up visit. He had elevated total cholesterol, triglycerides, and LDL. He has already implemented diet changes and increased physical activity. His recent liver studies were LDL of 125 milligram per deciliter and HDL of 128. An appropriate next step for therapy would be, your answer should be B, niacin, and the other name is niaspan, vitamin B3, nicotinic acid. Okay. Used in treatment of elevated cholesterol levels, this class of drug acts to increase high-density lipoprotein levels. Niacin is thought to inhibit apolipoprotein A1 breakdown. Now, this apolipoprotein is responsible for the transportation of HDL in the circulation. So, having more apolipoprotein A1 around would increase HDL levels, resulting in elevations of HDL levels by 20 to 30 milligram per deciliter. Niacin is thought to have many effects on lipid metabolism. It has been shown to decrease lipolysis in adipose tissue. So having less breakdown of adipose tissues will decrease the concentrations of very low density lipoprotein and low density lipoprotein in the blood. The primary mechanism of action is probably inhibition of very low density lipoprotein secretion, which in turn decreases production of LDL levels by 10 to 15%. Clearance of VLDL via the lipoprotein lipase pathway also results in lowering of triglyceride levels by 20% to 80%. Recent trials have failed to demonstrate a clinical benefit of niacin in lowering cardiovascular events rate. Side effects are, when taken in large doses, niacin or nicotinic acid can cause vasodilation with resultant flushing, dizziness, and nausea. Flushing, which can be decreased by co-administration of aspirin given 30 to 45 minutes before taking niacin. And the other effects that you can see are eczema, hyperuricemia, which may exacerbate gout. Some niacin products contain tartrazine, which is the FDC yellow dye number 5, and that should be avoided for patients with the aspirin allergy. Because of its tendency to GI irritation, niacin should also be used cautiously for patients with a history of peptic ulcer disease. The extended release form is linked with hepatitis. A 34-year-old pregnant woman with familial hyperlipidemia and elevated LDL levels. How would you treat this pregnant woman? And your answer is D, bile acid binding resins. Familial hypercholesterolemia is a genetic disorder. It is caused by a defect on chromosome 19. The defect makes the body unable to remove low-density lipoprotein. So it's the bad cholesterol. It's not being moved out of the blood. Okay? This results in a high level of LDL in the blood. Bile acid sequestrants such as Colstead, the other name is colestipol, and cholesterol triamine, which is the other name is questrin, okay, are drugs that affect absorption of fat and cholesterol in the intestine. Bile acid sequestrants exchange chloride ions for negatively charged bile acids, promoting a 10-fold increase in bile acid excretions. The increased clearance results in enhanced conversion of cholesterol to bile acids by the liver. Increased uptake of LDL from plasma results from the upregulation of high affinity LDL receptors on cell membranes, especially in the liver. The net result is decreased LDL levels by 10% to 35%. HDL levels increase by 5%. Triglycerides may also rise initially, but then they return to baseline within a few weeks. The bile acid sequestrants' major problems are GI effects, including constipation that may be severe and result in impaction. Constipation is more common in older adults. A laxative or stool softener may be helpful. Other GI symptoms include flatulence, nausea, vomiting, and abdominal pain. Headache is also common. Reduced folate levels have been reported with long-term use, so supplementation with folic acid is suggested. A fairly rare symptom is a burn odor to the urine. Bile acid sequestrants may elevate serum triglycerides, so they would be inappropriate to use in patients with high triglycerides and are contraindicated in patients with triglycerides equivalent to or greater than 500 milligram per deciliter. Yes, anything greater than 500 or more of triglyceride level will cause the patient to have pancreatitis. Niacin, fenofibrate, and gemfibrozil are pregnancy category C. Risk and benefits should be weighed. All the reductase inhibitors are pregnancy category X. So that's your statins. So do not give them to pregnant women or women who have the potential to become pregnant. No pregnancy category has been assigned to the bile acid sequestrants because they are not absorbed systemically. All anti-lipidemics should be avoided during breastfeeding. A 48-year-old diabetic with a history of gout, peptic ulcer disease, hyperlipidemia, and high triglyceride level of 350 milligram per deciliter. His LDL is 110, and he has a history of myalgia with statins. You proceed to prescribe him with, your answer should be C, fibric acid derivative. Although statin drugs are preferred first line for diabetic dyslipidemia, fibric acids are acceptable alternatives for patients, just like this one, for example, who's actually unable to take statins due to adverse effects. Fibric acid has a favorable efficacy profile for diabetic patients with dyslipidemia by reducing triglyceride and increasing HDL level. Ideally, you want the triglyceride level to be less than 150 milligram per deciliter. Fibric acid derivatives are gemfibrozil. The other name is lipid, and fenofibrate, and the other name is tricor. So the fibric acid derivatives increase lipolysis of triglycerides via lipoprotein lipase, resulting in decrease of 50% or more in triglyceride levels. A decrease in very low density lipoprotein is also related to decreased secretion by the liver. HDL levels increase by 15% to 25% as a direct consequence of decreasing triglycerides, and not by direct action. The reduction of triglycerides by fenofibric acids does not independently benefit the cardiovascular outcomes of the patient, but it dramatically reduces the risk for pancreatitis that occurs with triglyceride levels over 400 to 500. So the goal for this patient is to have his triglyceride levels decreased. If if his triglyceride levels was more than 400 or 500, it would cause this person to have acute pancreatitis. So gemfibrozil and fenofibrates are good triglyceride-lowering drugs. Bile acid sequestrants like colsavelum would increase this patient's triglyceride levels and would not be the best option here. The ezetimibe, which is the Zetia, is unlikely to decrease his triglyceride level by not that much. The decrease would be about 5 to 10%. Niacin is used with caution with unstable cardiovascular disease, patients who have diabetes, active gallbladder disease, gout, patient with a history of hepatic impairment or alcohol abuse or renal impairment. Niacin would not be recommended in patients with active peptic ulcer disease or pre-existing diabetes, as in this case. Niacin may worsen peptic ulceration and may increase serum glucose, which may also result in loss of glycemic control. Adverse effects are increases in liver function tests, headaches, abdominal pain, myalgia, constipation, nausea, CPK increases, back pain, gallstone formation, rhabdomyolysis. Drug interactions, the fenofibrates may increase the levels of colchicine and Zetia. The HMG-CoA reductase inhibitors, so your statins, so fenofibrates would happen to increase these levels. Sulfonylurea, vitamin K antagonists. Gemfibrozil may increase the levels of diabetes drugs, carvedilol, colchicine, Zetia, statins, and vitamin K antagonists. Fibric acids may decrease the levels of cyclosporin. Levels of fibric acid may be decreased by bile acid sequestrants. LFTs should be monitored regularly. We've talked about bile acid binding drugs, statins, your ezetimibe, that's your Zetia, fibric acid, derivatives, and niacin. Now, the new kids on the block are a couple of drugs that was approved by the FDA in the summer of 2015. These are the PCSK9 inhibitors drugs called Praluent. The other name is called Alirocum, and the other drug is also Repatha, and the other name for it is Evolucumab. The acronym PCSK9 is proprotein convertase subtilisin kexin type 9 inhibitors. These drugs prevent the binding and the degradation of LDL receptors. So there are more receptors available to remove LDL from the blood. These drugs interfere with the synthesis of proprotein convertase subtilisin kexin type 9 in the liver. The liver protein is part of the natural synthesis of cholesterol in the body. In this PCSK9 liver protein is blocked by a targeted RNA particle then your cholesterol level drops. Paralint and Repatha are very expensive drugs, and they cost somewhere. A patient, would be charged somewhere, or the insurance would be charged somewhere like $10,000 a year, and they come in an injectable form. I've seen patients on it. The Praluent, the dosages are somewhere from 75 milligram to 150 milligram sub-Q, given Q2 weeks or Q4 weeks, depending on the schedule. And I've seen it prescribed along with Zatia or statins. I've seen also patients on the Praluent and Zatia. There was one in particular that comes in mind that had chronic elevation of serum creatinine kinase levels for unknown reason. And of course, this patient cannot have statins for that reason. Statins may cause myalgia, muscle weakness, and rhabdomyolysis. So up to 5% of the users develop CK elevation, typically 2 to 10 times the upper limit of normal. Another drug that's still probably in the clinical trials, it's been in the trials for a few years now, is the cholesterol ester transfer protein. So it's the acronym is CEPT, CEPTS. These proteins facilitate turning good HDL cholesterol into atherogenic VLD slash LDL particles. Drugs in the pipeline inhibit this protein, and it is hoped that they will increase HDL levels. Clinical trials on REVEAL, which is an acronym for randomized evaluation of the effects of anacetrapib, that's the drug name, through lipid modification, trial. This is the AIM trial, REVEAL trial, which aims to determine whether lipid modification with anacetrapib 100 milligram daily reduces the risk of coronary death, myocardial infarction, or coronary revascularization in patients with circulatory problems who have their low-density lipoprotein cholesterol levels treated with a statin. There's evidence from genetic studies that variants in the cholesterol ester transferase protein gene were associated with higher blood HDL cholesterol levels, low density lipoprotein cholesterol, and lower risk of coronary artery disease, suggested in the pharmacological inhibition of the cholesterol ester transfer proteins that may be beneficial. This goes way back to like in the early 1990s when certain Japanese individuals, they were discovered to have some sort of a mutation, and hence they've had higher levels of HDL cholesterol, the good cholesterol in their system. They studied 4 drugs. They had 4 clinical trials on it, and the only one that had a better outcome from the 3 drugs that were eliminated during the study was anacetrapib. Okay, so they found that anacetrapib doubled HDL cholesterol, reduced non-HDL cholesterol by 17 milligram per deciliter, and reduced major cardiovascular events by 9% over 4 years. But what they have found was anisotropic was found to have a lot of accumulation in the adipose tissues. So the regulatory approval is not being sought by the researchers. An 11-year-old overweight child with a total cholesterol of 180 milligram per deciliter and LDL of 125 milligram per deciliter, along with diet education and recommending increased physical activity, you ask to see the child in 6 months after you start which treatment plan? Your answer should be C, sterols. Sometimes a question like this would come up. Should children use cholesterol-lowering drugs? There are 2 reasons. The answer is probably not. First, these children are in no immediate danger. Their risk of developing clinically significant ASCVD in the next 20 years is close to 0. And second, the only data from randomized controlled trials were for children with familial hypercholesterolemia. No data exists to show that these drugs will improve outcomes when given to children with secondary lipid disorders. Eating sterol and stanol containing foods is an easy way to lower your LDL cholesterol, which helps reduce the risk of heart disease. Simvastatin, the other name is Zocor, also has an excellent research profile. The initial dose is 20 milligram to 40 milligram per day, with a maximum dose of 40 milligram per day. For adolescents between ages of 10 to 17 years with familial hyperlipidemia, the starting dose is 10 milligram per day with a maximum of 40 milligram per day. Lovastatin, the other name is Altoprev, has a mid-range adverse reactions profile. It must be taken with food. The initial dose is 20 milligram per day in an immediate release form, or 20, 40, or 60 milligram daily of the extended release form, with dosage increases at 6 to 8 weeks intervals to a maximum dose of 80 milligram per day. For adolescents with familial hyperlipidemia, the starting dose is 10 milligram per day with a maximum dose of 40 milligram. Pravastatin, the other name is Pravachol, is similar in potency and its adverse effects profile to lovastatin. The initial dose is 40 milligram per day with a maximum of 80 milligram. Pediatric doses for this drug are available for children as young as 8 years of age. For 8 years to 13 years, the dose is 20 milligram per day for both initial and maximum doses. For age 14 to 18 years, the starting and maximum dose is 40 milligram per day. Fluvastatin is about 1/2 as potent as lovastatin and has a mid-range adverse reaction profile. The initial dose is 40 milligram per day with a maximum dose of 80 milligram per day. Monitoring of a patient who is on a lipid-lowering drug includes, your answer should be B, lipid profile with attention to serum LDL 6 to 8 weeks after starting therapy, then again in 6 weeks. With good medication and adherence to lifestyle changes, patients should show a lowering of cholesterol within 4 to 6 weeks of initiating therapy. Levels of serum LDL cholesterol should be evaluated 6 to 8 weeks after initiating therapy. Nicotinic acid, that's niacin, is the exception to this rule. With repeat measurements done when the patient's prescribed dose that has been stable for 4 to 6 weeks, for all of these drugs, a second measurement of LDL cholesterol levels is done 6 weeks after the first measurement. A minimum of 2 measurements is used for establishing the efficacy of the treatment plan. For all treatment regimens, if the dose of a drug is increased or another drug is added to the treatment regimen, the patient's laboratory data should be evaluated in another 6 to 8 weeks. An aggressive increase in dosing is recommended for those in highest risk for cardiovascular disease per the new guidelines. After the desired LDL cholesterol range is reached, patients should be followed at 8 to 12 weeks intervals for 1 year. After 1 year of therapy, during which the patient's response to the treatment regimen has been established and there is no evidence of toxicity, patients should be followed at 4 to 6 months intervals. Myopathies tend not to surface until 9 months into therapy. Evaluation of CK levels after the baseline period is not indicated unless there are symptoms. Before starting therapy with a statin, which of the following baseline laboratory values should be evaluated? Your answer should be B, liver function and CK. Okay. Monitoring for effectiveness of dietary therapy involves weight loss, BMI reduction, and lipid lowering. Drug therapy is not usually initiated until a 3-month trial of dietary therapy has been completed. The exception is concurrent drug therapy for those patients with diabetes mellitus or metabolic syndrome. Selection of an agent to treat a lipid disorder is based on a minimum of 2 lipoprotein levels done 1 to 4 weeks apart during maximum dietary therapy and on individualized risk. This provides a baseline for future evaluation of whether a drug needs to be added to improve treatment efficacy. Baseline lab data, your liver function test, that's the aspartate transaminase, the AST, and ALT, which is the alanine transaminase, or also known as alanine aminotransferase, and your creatinine kinase should be gathered before drug treatment begins. Serial monitoring of liver labs are no longer indicated for most patients. A 73-year-old man who suffered a mild stroke is being discharged from the hospital. His blood pressure is 155/96 millimeters of mercury, and low-density lipoprotein cholesterol is 112 milligram per deciliter. Which of the following medication treatment will you anticipate putting this patient on? And your answer should be B. Rosuvastatin 20 milligram QD plus hydrochlorothiazide 25 milligram QD. This patient will require blood pressure lowering because his blood pressure is over 140/90 millimeters of mercury. He will also require high intense statin therapy because he is less than 75 years of age. For adults who experience a stroke or TIA, treatment with a thiazide diuretic, angiotensin converting enzyme inhibitor, or angiotensin receptor blocker, or combination treatment consisting of a thiazide diuretic plus an ACE inhibitor is useful. Selection of specific drugs would be individualized on the basis of patient comorbidities and agent pharmacological class. Statin therapy is recommended for all ischemic stroke patients, regardless of baseline cholesterol, to reduce stroke recurrence. The statins have been shown to reduce the risk of stroke by approximately 30% in patients with coronary artery disease and elevated plasma lipids. The stroke prevention by aggressive reduction in cholesterol study demonstrated that atorvastatin 80 milligram daily reduced the risk of recurrent stroke by 16% and coronary events by 42% in patients with no cardiac history. Although the high-dose statin caused an increase in liver enzymes, there was no increase in myopathy. It is not recommended that patients age 75 or younger experiencing ischemic stroke of presumed atherosclerotic origin be treated with a high-intensity statin therapy for secondary stroke prevention with a target of achieving a 50% or greater reduction in low-density lipoprotein cholesterol. For patients older than 75, moderate or high-intensity statin therapy can be initiated as tolerated. If the patient is on maximally tolerated statin therapy but still has an LDL cholesterol of greater than or equivalent to 70 milligram per deciliter, ezetimibe may be initiated. That's the other name for Zetia. Okay, this concludes my video on drugs that are treating hyperlipidemia in a question and answer format. I hope you like this video. Please click on like if you do and subscribe to my YouTube channel for more videos like these. Thank you for watching and have a great day.